Good afternoon, everyone. What I'll be discussing in next 10 minutes or so, but very important topic. Whenever we are trying to control the type 1 or type 2 diabetic, specifically with a secretagogues or insulin, the chances of hypo is always there. And the most dreaded aspects of the hypoglycemia is hypoglycemic unawareness. And we'll try to see how actually we can try to restore the warning signs of hypoglycemic unawareness. So we'll talk about what is hypoglycemic unawareness, where actually it occurs, how to diagnose, and are there any measures to restore the warning signs. As we all know, as the name suggests, that diabetic patients are not able to recognize the warning or early symptoms of hypoglycemia, initially adrenergic and subsequently neuroglycopenic symptoms also, and they are not able to correct the hypoglycemia by taking the appropriate measure. And this increases the chances of development of severe hypoglycemia. What happens when the patients with diabetes has a recurrent episodes of hypoglycemia? They have loss of the characteristic warning symptoms, and unfortunately, they have got a attenuated counter-regulatory hormone response. So, counter-regulatory hormones does not rise in the response to the hypoglycemia. So, it is termed as a impaired awareness also. And if there is a less symptoms with less response of a counter-regulatory hormone, it is caused as termed as a hypoglycemia associated autonomic failure. And the prevalence is around 25% in type 1 and 10% in the type 2 diabetic patient, and it increases the chances of severe hypoglycemia is increased by 6 to 25 fold. So that's a very dreaded complications of a diabetic management. So how actually the hypoglycemic unawareness develops? Recurrent episodes of hypoglycemia is actually one episode of hypoglycemia can lead to another episode of hypoglycemia. So somebody had hypoglycemia, he or she is likely to get another episode of hypoglycemia. So our role is to avoid this hypoglycemia. Because of the recurrent episodes of the hypoglycemia, brain glucose sensing becomes impaired. So neuronal response to the counter-regulatory hormones actually is significantly reduced. So patient's brain does not respond to the hypoglycemia, and there is a counter-regulatory hormone also is impaired. In the sleep, we have seen lots of people who have a nocturnal hypoglycemia. Actually, sleep fails to respond to the hypoglycemic symptoms as well as the counter-regulatory response. And as we all know, antecedent exercise, specifically unaccustomed exercise, also can lead to hypoglycemia. So this is a mechanism actually by which the hypoglycemic unawareness occurs. One is the intensive glycemic control, prior episodes of recurrent or severe hypoglycemia, longer the durations because of the renal and hepatic insufficiency, alcohol consumption, exercise, sepsis. So all this tool leads to the altered brain glucose sensing, cerebral adaptation to the hypoglycemia, so it does not respond strongly to impaired hormonal counter regulations. So how actually we can diagnose the impaired awareness of hypoglycemia? So there are several patients. I'm not going to detail it, but there are lots of questionnaires which is focusing on the hypoglycemia. So it's just a simple question of one sentence. Do you know when your hypoglycemic episodes are occurring prior to documentations, or suddenly sometimes somebody becomes unaware? The gold score, just as one simple question also sometimes helps. The class score questions, there is of 8 questions. And there are various questionnaires or simple one question there also we can do in our busy OPD. So how actually we should avoid the hypoglycemic unawareness? We should identify the people who are at a high risk of development of severe hyperglycemia or likely to have the hyperglycemic unawareness. So elderly gentlemen or females, insulin therapy with a tight control, comorbidities, young type 1 diabetes, patients on an insulin secretagogues, patients on any hypoglycemic agent with a very tight glycemic control are likely to have a hypoglycemia and subsequently hypoglycemic unawareness. So what is the main important aspect is to strict avoidance of recurrent episodes of hypoglycemia, which could restore at least partially awareness of hypoglycemia and may improve counter-regulatory response also. Even chronic episodes of hypoglycemia also can induce the hypoglycemic unawareness. So if you want to restore, first and most important is to educate or sensitize the patient about the early signs of hypoglycemia, correct measures to correct the hypoglycemia, then some pharmacotherapy and technology. So this can restore the hypoglycemic awareness as well as the response the counter-regulatory hormones. So most important strategy is to avoid the hypoglycemic episodes. Even 2 to 3 weeks of strict avoidance of hypoglycemia can start reversal of the hypoglycemic awareness, and patient may start having the warning symptoms. So we should be having the individualized glycemic targets. We should have a comorbid conditions. We could have a more liberal targets. And this is very important. Using agent with no hypoglycemic risk are to be preferred for at least 6 to 8 weeks. So somebody has hypoglycemic unawareness, try to have a more liberal target. Avoid the agents which can lead to hypoglycemia if possible. So this would significantly increase the chance of the reversal of hypoglycemic unawareness. And if the patient requires secretagogues or insulin, try to give the short-acting secretagogues or a newer insulin analogs with a less potential to develop hypoglycemia. To avoid the nocturnal hypoglycemia, give the insulin analogs which has a less chance of nocturnal hypoglycemia. Ask the patient to have the bed snacks, like uncooked corn starch, specifically those who have got a significant nocturnal hypoglycemia and who needs a secretagogues or insulin, them to take a bedtime uncooked corn starch to reduce the chances of hypoglycemia, or they can have the some pharmacotherapy. Education predominantly focuses. There are lots of protocols are available about the education and showing a good response. But most important is that hypoglycemia focused education is a very crucial, and close monitoring of the hypoglycemic symptoms and correction is very important, which is actually we should be constantly asking the patient about the hypoglycemia, those who are at a risk of hypoglycemia, like a secretagogues or an insulin therapy. Now about the technology has helped us a lot. Previously, we were depending only on the symptoms of hypoglycemia, and then patient had a severe hypoglycemia. And now with the better technology, like with a continuous glucose monitoring or a glucometer, before the symptoms occur, patient can know that patient has developed hypoglycemia. So neural diabetic technology for assessing glucose levels, like a CGM with a sensor augmented insulin pump or automated insulin delivery system, can decrease the episodes of hypoglycemia and can help to improve the hypoglycemic warning symptoms. Like CGMS, patient have a alert for the impending low sugars, so patient can take the corrective measure before actually symptoms starts. So it will avoid the vicious circle of recurrent hypoglycemia and may improve the hypoglycemic awareness. Like Diamond trial showed that there was an improvement. The CGM restored symptoms of 50% of the patient with a impaired hypoglycemic awareness within 6 months in a type 1 diabetic patient. So technology does help. Then there is a closed loop system which also helps, and there is a sensor augmented pumps where when the blood sugar is on the lower side, the pump is suspended, so it will improve the hypoglycemic awareness. And there is a automated insulin delivery systems also are there, which can help to help the improving the hypoglycemic awareness as well as improving the counter-regulatory response to the hypoglycemia, and subsequently makes the patient's life more easier. With all the possible therapy, sometimes patients' hypoglycemic unawareness does not respond, and patient still have hypoglycemic unawareness, and patient requires the secretagogue insulin for the other diabetic management. The ADI recommends to have the islet or a pancreatic transplant. So sometimes you can understand that hypoglycemic unawareness is one of the indication of a islet cell transplant or a pancreatic transplant, which is not feasible in our country. But our role is to avoid the hypoglycemic unawareness to develop and try to correct the hypoglycemic unawareness as early as we come to know that patient has started having a unawareness of hypoglycemia. Now there are certain pharmacotherapy apart from anti-diabetic management that has been tried, like in response to the hypoglycemia, the targeting the adenosine receptors blockage to increase the alertness and enhance the secretions of the counter-regulatory hormones. The drugs like theophylline has been studied, caffeine has been studied to improve the hypoglycemic awareness. The SSRIs also in a non-diabetic hypoglycemic as well as diabetic population has been tested to improve the symptoms as well as augment the counter-regulatory response. Very interesting. Sleep deprivation and restoration of hypoglycemic awareness. You all know that during the sleep, hypoglycemia gets unnoticed. So if you have some patients who have a hypoglycemic unawareness, what happens if they are deprived of the sleep? In extreme cases, but there are studies that counterregulate response of the key hormones like epinephrine, growth hormone, and glucagon were significantly reduced after recurrent episodes of hypoglycemia when patient slept regularly compared to sleep deprivations. Even neuropsychiatric symptoms during hypoglycemia also is preserved upon sleep deprivations. So sleep loss after repeated hypoglycemia could prevent the hypoglycemic unawareness. So it is a very interesting, and it requires lots of further studies that severe cases of hypoglycemic unawareness, whether we should try for the at least some sleep deprivations. So most important take home message is sometimes it's very difficult to reverse the warning signs of hypoglycemia. So most important, try to avoid the hypoglycemia in the early phase of diabetics, where now we get excellent agents which are non-hypoglycemic agent. So we can have a tighter glycemic control without increasing the risk of hypoglycemia. Number two, if somebody develops hypoglycemia, because many patients would require ultimately secretagoguer insulins, and every newer agents also has a chance of hypoglycemia. So one episode of hypoglycemia, the likelihood of a second episode of hypoglycemia is there. So at least for a couple of weeks, make sure that patient does not develop second episode of hypoglycemia. If the patient has any suggestion that patient is not able to recognize the hypoglycemia, try to have the more liberal standards of the hypoglycemia. Sometimes the question comes that somebody is sitting in our clinic with a 30 or 40 blood sugars talking to you normally, and patient is surprised that my sugar is 35 or 40, and sometimes with a 50 blood sugar somebody is in neuroglycopenic symptoms and admitted with a coma or a convulsions. So the drop, there is a rapid drop of the blood sugar, body does not respond as rapidly, specifically with the longer duration of diabetes, would have a more neuroglycopenic symptoms or a hypoglycemic unawareness leading to severe hypoglycemia. By gradual fall over a period of couple of hours would have enough time for the body to divert the glucose from the periphery to the brain, and patient would not have every day in a OPD we see a patient with a random blood sugar in the lab coming 44 or 45 and patient, and we as an endocrinologist also does not judge that patient was in hypoglycemia. So rapid fall is more dangerous for the hypoglycemic unawareness or the severe hypoglycemia. So now with the CGM, in tightly controlled type 2 diabetic or type 1 diabetes patients who secretagoguer insulins, if they can afford, we should be doing CGM to make sure that there is a rapid drop or not, patient has a hypoglycemic unawareness or not, how long patient was having hypoglycemia before he had a first warning sign of hypoglycemia. Sometimes patient had hypoglycemia for a couple of hours on CGM and patient noticed at 3 p.m. but hypoglycemia started at 1 p.m. So then also we can come to know. So we can use now technology and we can avoid the irreversible hypoglycemic unawareness. Thank you very much for your patience hearing.